Reams of copy have appeared on how global South countries, including those in the Caribbean, struggle to obtain COVID-19 vaccines to safeguard their populations during the pandemic. But our region's vaccine struggles began long before that once-in-a-century pandemic declared in 2020. Global South countries have faced an ongoing fight for many decades to obtain needed medicines, resulting in countless preventable deaths and morbidity.
And I think that part of the lessons learned is that we, as persons in the South, must have the capacities to do more with respect to how we take care of our population. I think that the waiting for a few crumbs off the table with respect to the spoils was not a good example of solidarity among nations.
This was a straight up power play in which the most powerful countries used all of their economic and political power to push these companies to make sure that they got doses first. And that's not surprising to those of us who study international politics, right? That the powerful countries regularly assert, especially when they're in moments of crisis, they assert their political power to ensure that their populations are well cared for. That shouldn't surprise anybody.
You just heard Barbados' Chief Medical Officer, Dr. Kenneth George, commenting on the indignities Caribbean countries suffered, and Dr. Matthew Kavanagh, Professor of Global Health and Law at Georgetown University in the US, summing up what actually took place during the recent pandemic.
This podcast documentary, funded by the International Women's Media Foundation, takes a look at the ongoing systemic issues in the global pharmaceutical supply chain and the serious threat these pose to the well-being of the Caribbean and other global South countries during major health emergencies,
as well as what that could mean for our future well-being. The Pan American Journal of Public Health basically lays out the problem the Caribbean and other South countries faced during the pandemic. In a 2022 research article by two Brazilian university academics dealing with World Health Organization research and development initiatives for COVID-19 to promote equitable innovation, the authors state unapologetically that, quote, high-income populations had access to vaccines and other health technologies much earlier than others, because the traditional market dynamic of supply and demand was the main driver for allocation of such products, even though the World Health Organization and partners tried to implement initiatives based on equity. The same scenario happened in other pandemics, such as HIV/AIDS, in which lower-income countries had to struggle to access the available life-saving medicines. End quote. That journal article looks specifically at the COVAX facility, established ostensibly to ensure that the Global South got its fair share of the vaccines along with the rest of the world. COVAX was one of the three main pillars of the Access to COVID-19 Tools Accelerator, otherwise known as ACT-A, launched in April 2020 to strengthen health systems. Within 2 years, ACT-A had received more than $20 billion US in financing, most of it from public funds, and 2/3 of that money was put toward the COVAX pillar. Gavi's chair in 2020,
current Director General of the World Trade Organization, Dr. Ngozi Okonjo-Iweala,
explained how it was meant to work in this audio excerpt taken from the Central Bank of Barbados' website.
So in terms of facilitating the distribution, what percentage of populations do you think you will be able to assist through this COVAX program?
Well, so much of that depends on our ability to acquire the 2 billion doses that we talked about. Luckily, we have an understanding or MOU with AstraZeneca already for 300 million doses or more. We're in discussion with Pfizer and Moderna at the moment. So we believe that we'll be able to cover across the board in all our countries the frontline health workers. So that will be maybe the first 3% or so of the vaccines we acquire will go to all of those. across all countries so that no country's health workers need to wait in line. And then the next set will be 20% of those who need to be vaccinated in each country. But countries will have to decide for themselves which set of people do they want to target. Is it the older population, the most vulnerable, those who have underlying conditions? Is it younger people? They'll have to make the decision. Of course, there'll be some guidance from the WHO on this. That's where we are now. We'll be able to cover the first maybe 23%, and then we'll take it from there. We'll try to acquire more doses to go beyond that.
However, as the journal article authors explain, high-income countries instead, quote, chose to guarantee doses on a bilateral basis with manufacturers so they could fully vaccinate their populations long before priority groups were vaccinated in other countries. This undermined the mechanism, end quote. Dr. Kavanagh, who is also director of the Global Health Policy and Politics Initiative at Georgetown, puts it more simply.
Okie doke. The recording is on. There's just a ton of really interesting stories that are out there of, presidents on the phone with CEOs, promising them all sorts of things if they can get more doses.
Instead of the most vulnerable population segments and healthcare workers across the globe receiving priority in obtaining vaccines, once they became available, most doses went to the north for several months, while the Caribbean and others got merely a trickle.
And so you had young, healthy, well people getting vaccinated well before the health workers and the elderly of the global south, and that promise that had been made about achieving equity really went out the door because no politician actually wanted to tell their population, you'll have to wait so that we can actually share with others. It didn't happen from any of the powerful countries, and that was a real tragedy.
He believes this imbalance was a major contributor to the development and spread of the many variants. Dr. Kenneth George said Barbados got its first supply of vaccines in 2021, a year after COVID arrived on its shores.
Those vaccines were through a kind donation from a country that had Barbados's interest at heart. And that was how we started the vaccine process. We were several months late, and I believe that the lateness in implementing our vaccine program may have contributed to some of the hesitancy that we saw creeping in soon after.
He said Barbados did join the COVAX facility soon after that donation.
And that was a difficult process in itself because COVAX was not a free facility. And countries were told that they will get vaccines at better rates, better prices, with more a supply that was more consistent. So we joined the COVAX facility, and we used that facility to source some vaccines, not many, but we were able to source vaccines from COVAX. But a lot of our vaccines in Barbados also came in from like-minded countries, and those countries, we are indebted to them for their willingness to share during a scarcity of vaccines. But as I said, countries within the region were never able to get a supply of vaccines consistent with the initial need.
In later stages, the supply increased, he added. That seems odd after $20 billion in funding and the EU graciously donating €3 million to the region through the Caribbean Public Health Agency to obtain vaccines via COVAX and other treatments. But perhaps the reason COVAX did not deliver is because it was set up not so much to help countries like ours, but as a device to protect the pharmaceutical industry's profits. The PAHO Journal article referenced earlier explains, quote, despite a principle of global solidarity and access by lower income countries, this mechanism to some degree favors the donors themselves by returning revenue to their industries. The recurrent problem of access to innovative technologies indicates that it is a structural problem. Health technologies are a public health asset and should be treated as such, but their development, production, and distribution are oriented by traditional market mechanisms. End quote. The companies, Dr. Kavanaugh said,
that they mostly wanted to serve the nations that were the most powerful, that were not only willing to pay top dollar in terms of a dose price, but are also the places that funded them. These are companies, of course, that, as we talked about, depend on billions and billions of dollars in research and development funding.
Dr. Kavanaugh said in 2022, the global pharmaceutical industry was valued at $1.4 trillion US dollars, with half of that value concentrated in the US. Much of the funding for its research and development comes from the US Congress. Likewise, European Union pharmaceuticals receive major funding for R&D from their governments.
And the thinking behind that is not just that they want to prolong life and save lives. It's absolutely that they want to maintain a competitive edge. And that is part of why the United States economy is as strong as it is. Ensuring that the kind of US remains technologically dominant is an incredibly important national goal of the United States, and comes out of, hundreds of years, I would argue, of colonialism in many ways, right? It's not a mistake that the United States has the economic power that it does, or that Europe has the economic power that it does. And so to me, when I think about vaccine inequalities and things like that, I think we take it all the way back to that conversation to understand that, some economies are hugely strong because of historical patterns, and that enables them to invest in R&D. It's not just that the United States is more innovative or smarter or somehow more technologically advanced than the rest of the world. It's that we have billions of dollars that we're able to put into those industries, and that gives our industries in the United States huge competitive advantage around the world. We've seen this again and again, that gap is really about resources.
He said drug companies are also legally obligated to ensure profits for their shareholders, and it is therefore up to governments to impose regulations that ensure equitable access to vital medications like the COVID vaccine. As for the COVAX facility, some hold the view it may have been established as a way to deflect attention away from the more realistic option of sharing the COVID vaccine technology with regions like ours. As the Brazilian authors noted, there is, and I quote, chronic inequity of access to health technologies, since such access is caused by a structural monopoly of power of dominant agents, either countries or companies, whose modus operandi has not changed, and companies are reaping great profits from the pandemic. The proposal to temporarily suspend intellectual property rights on essential health technologies for COVID-19 has been struggling to gain traction and is far from being implemented. End quote. Global South countries, organizations like Gavi, and the World Health Organization are continuing that struggle on several fronts in relation to several other vital vaccines. In the foreword to its 2022 Global Vaccine Market Report, the WHO's Director General states, and I quote, while COVID-19 reminded the world of the immeasurable power of vaccines as key public goods, it also highlighted inequities in access that are sadly the rule rather than the exception globally. Lower income countries struggle to access vaccines that are in demand across the world. For example, the human papillomavirus vaccine, which protects against cervical cancer, has been introduced in only 41% of lower income countries, while it is saving lives in 83% of high income countries. Regions without sizable manufacturing capacity of their own lose out, and intellectual property monopolies continue to severely limit access to vaccines. End quote. On the other hand, the report notes vaccines to treat diseases that rarely affect North populations receive, open quote, suboptimal investment, few pipeline products, extended timelines, and delays in availability, end quote. Realistically, global South manufacturers will continue to be reliant on the vaccine technologies developed by major pharmaceuticals in Europe and North America. Vaccine development is a formidably expensive undertaking, requiring the outlay of millions, even billions of dollars, and few countries in our part of the world can afford such expenditure for research and development. But South countries are happy to pay patent licenses for use of intellectual property. Scientists I spoke with agreed that throughout Africa, Asia, Latin America, and the Caribbean, there are scientists capable of using that intellectual property to develop viable, lower-cost versions of the medicines for use by our own populations. That is what happened when they were allowed access to the intellectual property behind antiretroviral medication used in treating HIV. That wider accessibility led to a major improvement for patients living with HIV in the region, says Dr. Shanti Singh Anthony of CARICOM's PANCAP, the Pan-Caribbean Partnership Against HIV. In the early days, diagnosis was not readily available in Guyana, and most people entered treatment only after they had already progressed to the stage of full-blown AIDS, she said.
They came in already with AIDS. That, coupled with the fact that medicines were not readily accessible, really led to high mortality rates. And so deaths, there were significant numbers of people dying with HIV. There was significant morbidity, as you stated, because people came in with the most severe forms of opportunistic infections. So people came into HIV programs with TB, for example, with toxoplasmosis, and that in itself also led to high rates of mortality. Globally, these drugs, the ARVs, they were approved by the different FDAs, but we did not have available generic forms of the ARVs. And the branded ones, the price sometimes can be very prohibitive. But once the generic formulations came on board, then resource-limited countries, third world settings, were able to access the generic versions of the medication. And I think that's when it became more accessible to persons.
The result has been a remarkable shift in quality of life for those living with HIV.
They're going back to the workforce, so they're contributing to the country's development. They're looking after their families. Generally, they're leading a normal life. And so I think, like I said, we're in a good place, a single pill. And with the kind of quality of life that people are getting, it's HIV has now become almost as if it is, and in some cases has been classified as a chronic disease. It has normalized the way people live with HIV, the way they live their lives now, and has contributed, I think, to a better quality of life for people living with HIV.
Dr. Kavanaugh said 3 different developments combined to break the monopoly of the pharmaceutical industry on antiretroviral medication, which led to cheaper generic options becoming available globally, though only after several millions of South citizens had died. The first and most visible was the insistent demands of activist groups around the world demanding action from government.
But the second thing that's much less high profile is that actually governments of the global south issued compulsory licenses, which is a provision within the international trade regime that allows a government to say, okay, you may have a patent, but we are ordering you to share that information so that we can make it generically. And then the third thing that happened, of course, was that funding came in and the funders started buying those generic drugs. They created a market for low-cost drugs. And what was transformative was that only after those things happened did the drug companies realize that they couldn't come on and have a monopoly worldwide over those drugs. That exact same thing could be done for COVID vaccines or for COVID treatment, but well beyond COVID, to think about what's the next pandemic to come. There's a wide variety of medical tools out there that we could be using that model for. But the pharmaceutical industry has been very powerful and pushing back against that and threatening governments and saying you can't do that.
Of course, even with more available vaccines, vaccine hesitancy persists. But as Dr. George mentioned earlier, it was likely exacerbated by delays in obtaining supplies. Jelani Williams, who works in the oil and gas industry, agrees with that opinion. As a responsible 42-year-old husband and father of 5, he opted to be fully vaccinated, but still contracted COVID and was warded at an acute care facility in Cora in Trinidad.
So the vaccine we got, both my wife and I, was the Sinopharm, and we got both the first and the second dose. The booster came out later. But when we contracted it, we were fully vaccinated with the both Sinopharm.
He admits harboring reservations initially.
I definitely had concerns because you were hearing so much negative effects from the anti-vaxxers. There were even doctors who were part of the whole anti-vaccine thing. So, of course, you question whether is the information, legit? Is it not legit? So, yes, you would have questions, and yes, you would have anxieties based on the amount of negative that was out there against the vaccine.
But he is still glad he took the vaccines despite contracting the illness anyway.
So the vaccine, and in thinking back, I believe the vaccine would have had a positive effect in the context of seeing the patients in Coral who were unvaccinated and what they went through was far worse than what I went through.
He said delays in the Caribbean gaining access to the Pfizer vaccine for school-age children, like his daughter, was also a cause for concern.
And children, they wouldn't have the ability or the discipline that adults would have with regards to carrying out the necessary measures, preventative measures. So viruses tend to spread a lot faster through a school system.
And for school-age children, being forced to attend school online added to the pandemic pressures. Sulin, who completed secondary school in 2021, told me attending school online made it difficult to be disciplined.
When we was online, everybody got lazy. So all the work will depend on one person, group leader. They make sure that they have for every single assignment, like for the English, one person will make sure it has everything, and that part was stressful for that person, and it was a group project, so that part was kind of stressful online. But when we was in person in school, everybody was doing what they were supposed to do.
So when the vaccine became available and she could return to in-person classes, she was glad. Though vaccination was not mandatory, she opted to be vaccinated since she wanted that extra layer of protection.
Well, one, because my mom has some comorbidities, so she wanted to get a fighting chance, and she didn't want to take the risk. I think it was basically for people who wanted to take it because they wanted to protect their family and not pressured to take it. If they didn't want to take it, it's fine.
She sums up nicely why we in the Global South need to care about the pharmaceutical industry's stranglehold on vital medications.
Like they said, it wasn't a cure, it was just a fighting chance, because that's how they promoted it to everybody, basically.
The current system, concentrated within a few powerful companies and countries, reduces that chance.
It's a system that works for the handful of companies that are really exercising monopolies, but it's a system that's really bad for actually ensuring that we have innovation on the one hand and access on the other.
Thank you for listening. This podcast on systemic issues in the global pharmaceutical supply chain and its impact on the Caribbean was funded by the International Women's Media Foundation. Thank you to my audio engineer, Owen Shade of InShade Productions. The podcast was written, produced, and presented by me, Jewel Fraser. Thank you for listening.